Hey guys, welcome back to Medical Coding with Blue. Today's episode is all about sequencing tips. Okay, this is probably like one of my most frequently asked questions. How do I know how to sequence? There is Optum 360, their ICD-10 book, right? And I always talk about Optum 360 all the time. This is not an ad for Optum 360, but I'm just saying some of these books are some of the best in the industry when it comes to helpful books for medical coders. In their ICD-10 book, they have an appendix. Now that appendix will give you a list of like codes that are first listed, okay? So if you ever have a situation where you're looking at a record and you see, like, for instance, the patient's coming in for a pre-op. Well, we know that Z01818 is a first listed only diagnosis code, okay? So we know that that's going to be the first listed diagnosis code. Now, when you are looking at the record and you're having to think about why is this patient coming in, that should be the first question that you ask yourself. And never trust pre-selected codes. I say this a lot because sometimes providers will pre-select codes, and sometimes the medical coder will think, oh, okay, well, if the provider selected this, then that's the order that needs to go in, and I'm just going to go ahead and submit it this way. No. You have to look at the record itself, and then you have to decide what order to put things in. Now, providers can select their own diagnosis codes, sure, but we as medical coders have to have their back and make sure that everything that is being selected is actually what is being reflected in the documentation. Now, if we're looking at a record and we're seeing that it says that this patient is here for a pre-op, say for instance they're going to have a lap band surgery. Now, why are they going to have this lap band surgery? Because they have morbid obesity. So the first listed code would be that Z01818, right, which is the encounter for a pre-op, followed by the reason that they're having that, which is for the morbid obesity. Now, say for instance the same patient also has OSA, which is obstructive sleep apnea, and they also have diabetes and hypertension. So we're going to use that diabetes hypertension combination code, right? And that's going to be sequenced the following, okay? Followed by the obstructive sleep apnea, which is just as important. However, when it comes to like hypertension and diabetes, obviously a patient who is on long-term use insulin and, medication for the hypertension, this is going to affect their ability to be able to take care of this patient. And they have to make sure that their blood sugars are controlled before they can have this surgery, and that they are on the appropriate amount of insulin and medications. So because this is so important, actively important, because it involves medication, okay? Then we know that these are going to be those third and fourth listed diagnosis codes. Now that combination code, I mean, you have no control over the second code, okay? But so from there, you're going to go with the obstructive sleep apnea. I was going to say OSA again. You're going to go with the obstructive sleep apnea because obstructive sleep apnea is very crucial when the anesthesiologist is getting their information. They need to know if this patient has obstructive sleep apnea because it does affect their ability to be able to put the patient to sleep. Okay, so they have to look at all of these factors. And so obstructive sleep apnea is very important. And sometimes you may notice when you are going in for a pre-op, they will ask you, do you have acid reflux? That's another condition that needs to be picked up if it is in the documentation and if it applies, okay? In which, in this situation, of course, I'm just thinking this stuff off the top of my head, then it would. But I'm not going to talk about the reflux, but more of the obstructive sleep apnea. So that would be sequenced fifth. Yes, 1, 2, 3, 4, 5. Yeah. So it would be sequenced fifth. Okay. Then we're going to look at long-term use insulin and then long-term use medication for whatever they're on for the hypertension, and then the BMI. Okay. Now, why did I think to put the medication before the BMI? Because the BMI is giving us more information, sure. However, the medications are going to play a lot more of an active role in the provider's medical decision making, okay? Because they still have to think about and consider these other medications. So in this instance, I would put those medications first before the BMI, okay? And so when it comes to like your history codes, your BMI codes, your long-term use medication codes, the question you should ask yourself is, how much is this related to what is happening? Does the provider have to consider these things, and how much of this additional information do they have to consider? Okay, so that is what I am thinking of. And because of the simple fact that with hypertension and diabetes, if the patient is on medication for these, this is why I would rank this higher than obstructive sleep apnea. Yes, obstructive sleep apnea is very serious, but when it comes to conditions that are most serious, I look at it like this patient is on active medication. And yes, they may be on a breathing machine for the obstructive sleep apnea, but when you're playing with like insulin levels, that's how I think of it, okay? So when it comes to like, as the list gets longer, it is going to be more about what is most important, okay? The most important things need to go at the top, and the most important things, whatever is affecting this patient's care, that is how you need to think about it. And also, how active is this provider in this patient's treatment of that condition, okay? And how much of that is going to affect the main condition. So another example that I want to give you guys is when a patient comes in for orthopedic aftercare. Now, I'm always going to talk about orthopedic aftercare because orthopedics and podiatry is my favorite specialties. I love medical coding, but I will say that orthopedics and podiatry is by far my most favorite. So I like to give a lot of good examples about this particular scenario. Say, for instance, a patient comes in because they're there for orthopedic aftercare, okay? But they're there to have sutures removed. Which code would you put first? The orthopedic aftercare or the suture removal? Because after all, they are there for suture removal. So which one would you go to first? Well, we know in the book, right, that one of the main codes is aftercare. So the reason that the patient is coming in is, yes, sure, it's for the suture removals. But why are they having sutures removed? Because they had a surgery. So we know that those aftercare codes are going to go first. Okay, so the aftercare following surgery for orthopedics, for orthopedic condition, that's going to be sequenced first, okay? In those scenarios where the patient is having an organic condition, they had a surgery for an organic condition. Now, what is an organic condition? An organic condition is something that the body is doing. Like osteoarthritis, if it is not post-traumatic, it's going to be an organic condition. So basically your M codes that you're looking at are going to be organic conditions. The body is doing this, okay? Chondromalacia is another example of something that the body is doing. So tendinitis is another example of the body doing this to itself, okay? So in any time that they're having surgeries for those kinds of conditions, then we know that's going to be orthopedic aftercare. But in the case that the patient is coming back and having the sutures removed, the first listed code would be that orthopedic aftercare, then the removal of sutures. Because yes, while that was the reason that they came in for the removal of sutures, why are they having these sutures removed? Because they had a surgery. So it's all about asking yourself the right questions, okay? Another example that I want to talk about is when the patient comes in for chemotherapy, okay? Now, the patient comes in for chemotherapy, they're going through the process of getting their chemotherapy, and suddenly they become dehydrated. So they have to get IV fluids so that they can get rehydrated again. What would be your first listed diagnosis? Would it be the encounter for the chemotherapy, or would it be the dehydration because the dehydration developed while they were there. So which would be your first listed diagnosis code? It would still be the encounter for chemotherapy, because the reason that the patient came in was for chemotherapy. The dehydration developed after they were receiving the chemotherapy. So then that would be your third listed diagnosis. So your first listed would be encounter for chemotherapy, followed by the malignancy that is being treated, whether it is the metastatic malignancy or the primary malignancy, whichever malignancy is being addressed, okay? And if it's more than one, then of course you work it that way as well. But then you would follow that up with the dehydration, okay? Because yes, they do have to do extra things now because they have to rehydrate this patient, but that is not the reason that the patient came in. The reason was that they were having chemotherapy, okay? So it's all about asking yourself the questions. And there is, I want to say that there is no roadmap, no direct roadmap, because every patient is unique. Every situation is unique. Every scenario is unique. But that's why I say it's important to know which questions to ask yourself. And asking yourself the question of why did this patient come in is going to eliminate a lot of frustration, okay? Then you're going to follow it up with how involved is this provider in this care, in the care of these other conditions, okay? And if they're not, how much is that condition going to impact how this patient is going to be treated, okay? Think about all the conditions that involve long-term use of anticoagulants, right? Like a DVT. A patient has a DVT and say, for instance, okay, I'm going to go back to my orthopedic roots again. I think it's good because a lot of people tell me, they complain. I will get emails complaining, Blue, I do not like coding orthopedics. Why do you like it so much? I don't know. I'm a freak, I guess. I don't know. But think about it like this. If a patient has a DVT, okay, and they're on long-term use anticoagulants, and let's just say they broke their arm, okay, is this relevant? Is this relevant to this patient's care? Yes, they had a DVT. Their blood's a little thin, and you're going to try to put them in a cast? Oh yeah, we need to be very careful with this. So when you think about like the injury codes, you're gonna anchor your injury codes first, okay? So if they fractured their wrist, okay, I always use a fracture of the wrist because it's easier. Fracture of the wrist code. Then you're going to follow it up with the DVT, okay? Then you're going to follow it up with the external cause code, right? And then you could follow it up with the long-term use anticoagulants. So that's how I would do it, because the external cause code is going to be, it's still a diagnosis code, and then the of course it is a diagnosis code, but it's it's the 7-digit code, I'm just saying. But the long-term use anticoagulants is more of information, additional information that is important. But when we come in and we're thinking about how are we sequencing, that is how I would think to sequence, okay? So that is, you know, my tip on that one. I am looking at the time just to make sure I got some more time. I'm good. Don't trust the sequence that the codes are being selected, okay, if you didn't sequence those codes, okay? Look at the reason that they're there. Look at what else developed. Obviously, if you're on the outpatient side and they came in with symptoms, and finally we have a definitive diagnosis, and those symptoms are all a part of that definitive diagnosis, you're not going to pick up those symptoms. You're only going to pick up that definitive diagnosis, and that's going to be your final selection, your first listed code, okay? So that is something else to think about as well. It is about looking at the documentation and understanding it. This is why I tell you guys that understanding what you're reading is crucial. It's not all about just picking up codes and oh yeah, just submitting it on through, and then just putting the procedures in order of whichever one pays the highest first. Yes, that is the rule on how we sequence procedures, but you still have to make sure that these diagnosis codes are still selected in the proper order as well. You know, these things, everything matters. Everything is looked at, and the way that we select these codes tells more of the story, okay? It tells more of the story. It tells more of why. Why did this patient receive care? What all happened, okay? So even though these conditions are very serious, like hypertension and diabetes, they're very serious, they're not going to be sequenced first if that is not the purpose of this patient's visit, okay? Because then it's wrong, right? If you just put those first because you say, well, yeah, that is really important, so I'm going to put that one first. If that's not the reason that the patient came in, then that would be wrong. That's when you're looking at that history of present illness and what is happening, what is the chief complaint, what is in the subjective section, what is going on. That is going to tell you the order. But knowing how to put the stuff in order and making sure that you're reviewing the appendixes, right, is really going to be key to helping you. Okay, so, oh, I want to sneeze. Okay, I'm not going to sneeze. I was outside earlier. All right, and they were cutting the grass too, so. But anyway, yes, that is my advice. Now, if you get it wrong, you get it wrong, right? And you're still learning. But take the time to ask yourself those questions. Why did they come in? How involved is this provider in that care of that condition? And how much does that condition impact the provider's ability to care for that patient? Okay, so that is the show for tonight. I hope you've enjoyed this one. I tried to make it a little bit different from the other sequencing video tips that I've given you guys by giving you different things to think about. But I hope you will join me tomorrow. Tomorrow is going to be about modifier 50. Okay, so be looking forward to that at 7:30. And I will go ahead and wrap this one up. So if you are a medical coder, a medical coding student, somebody curious about the fascinating world of medical coding, a provider or a nurse, I invite you to like and subscribe and follow me on my journey in medical coding. I will see y'all next time. Bye.